All right, I know a couple of folks will still hop in. Is everybody doing okay with the assignments? It looked like everybody got their reading quiz knocked out okay. Any issues along the way there? If so, feel free to shoot me an email. Likewise, if anything's going on, just let me know and we'll work around your schedule if we have to. That's not a big deal. So today we're going to talk about burns and some of the anesthesia considerations that come into play. Part of this is an understanding of burns and how they happen, and then part of it is understanding the treatment priorities for these patients. Has anybody worked in the burn ICU or done a lot of burn care in the past?
I used to work in the burn ICU.
Okay. It's kind of a unique beast. A lot of times you'll see that burns will get lumped in with the SI, but if you have a facility that's big enough, they usually have a freestanding burn unit. The nice thing is they try to protect you. You don't get all the other patients dumped on you because they don't want like the cootie patients in there getting everybody else sick. The downside is you work someplace really hot. Patients tend to be there for very long periods of time. So kind of unique challenges that go along with it. All right, so we're going to kind of move through things right now. If anybody has any questions, just shout out. Just the way the screen's set up right now, I may not see stuff in the chat, but I'll take a break every couple minutes and take a look at it. All right. So there's different types of burns, and we kind of classify burns based off of how they happened as well as the extent of the injury. So big things we tend to see, usually it's going to be kind of a friction related or a true heat related exposure. Friction stuff is like if you think back to when you were a kid and you got like a rope burn. But you will also see that especially polytrauma patients will often have burn or burn-like injuries from being exposed to like sliding down the road after a motorcycle accident or being drugged by a vehicle, things like that. So those will cause kind of a grading injury. Heat is what we traditionally think of as burn injuries. The good news is that even though it's the most often occurring, it's also the most minor burn injury that we tend to see out of all the choices here. The extensive ones that we really have to deal with a lot are electrical burns. So think about people that came into contact with a live wire. A lot of times we will see this happen in power line workers. If you don't know anything about linemen, very dangerous job. They get paid extremely well. They're in high demand, but it's very unforgiving. I've seen more than one lineman that's either been killed or almost been mummified just from the burn injuries as a result of the electrical burn. Other things you'll see tend to occur on a lesser scale, fortunately, things like chemical injuries and radiation injuries. I'm not a chemist, so I'm not even going to pretend, but you will see that oftentimes chemical reactions occur and solutions either get splashed on people or through some explosive process, you'll get exposed to these chemicals and they can do all sorts of really weird things. Sulfuric acid's one that we really think about. Other ones like hydrogen sulfide, those sorts of things that can result in not only burn injuries, but also all sorts of kind of micro changes in the cells that can cause problems for you. Likewise, radiation injuries are not very common, but they are very devastating. If you haven't seen the movie Chernobyl or the series Chernobyl, it's kind of something to watch just to see exactly how things kind of transpire as far as the pathway to radiation burns. So when we start talking about heat burns, most often we consider a couple factors. The depth of the injury is oftentimes referred or as a result of three different things. So the temperature of whatever you were exposed to. So you can have things like a low exposure for a long period of time, or you can have a higher exposure for a short period of time and ultimately wind up with the same insult. The thickness of the skin. So one of the things we really talk about when we're referring to kind of critical burns is important areas. So think about things that are like either life or limb threatening or threatening. So burns to fingers, joints, toes, face, the critical 1% for men. Things like that tend to be very significant because the skin there is very thin. So a lot of times you'll see that even though it's a smaller burn, it becomes a little bit more important than say like a burn on your chest or forearm or something like that. Most of the burns involve the epidermis and dermis. There are more extensive ones. Most commonly, what we see is that burns occur as a result of exposure to hot liquids. We do see some burn exposures as a result of flame, but they tend to be pretty minor. Because most of us, if we have the ability and we're near something hot, will pull ourselves away. But if you've been exposed to something like steam, hot liquid, those sorts of things, they're very quick and it's very hard to get away from them. If you think about like a gas or a liquid that gets splashed on you or you're exposed to, it's kind of hard to get back fast enough. In electrical burns, what happens is basically the electrical energy is made you part of the circuit. So, like I was talking about with the linemen, for some reason they come into contact with something that's under great electrical energy, and then the energy passes through them usually to the ground. So you'll see a lot of times if they're working with stuff, they use things that are non-conducting, like wood or plastic, those sorts of things, so they don't become part of the circuit. So a couple different things happen here. We think about the burn side of things, but the other thing that happens is you have electrical changes inside the body, especially in our cardiac conduction system. So one of the biggest things you'll see talking about electrical burns, and this is moving away from linemen, you'll have kind of little mass casualty incidents sometimes, and it usually happens a couple times a year and makes the news, where people will be out at the lake, softball, baseball, something like that, and there's a couple people together, and there will be a lightning strike. And as a result of that, they may have physical burns where you're able to see the burn injuries, but more often what they have is a significant disruption to the membrane potential, and they will almost always go directly into ventricular fibrillation. So if you can imagine as an EMS responder, you pull up at a baseball game and there's not one person in cardiac arrest, but like 5 or 10, and then you have other people's with varying degrees of injuries. I know last summer here in the DFW area, it seemed a lot more common than it usually is, but we had a lot of electrical injuries from lightning strikes. I don't know why it was more pronounced last year than before, but did seem to be a decent number of them. So things that kind of come into play here as far as the actual burn problem, very similar to what you saw with heat injuries. It's really dependent on the path of the current. So one of the problems we run into is a lot of times people conduct the electrical or contact the electrical line with their hand, and then it grounds through the foot. So it's traveling all the way through the body. On linemen, what I commonly see is that they'll have both hands on the line, so it usually transmits from one hand all the way through to the other hand. The big problem with both of these is if you think about everything in between, there's some pretty significant stuff there. Heart, lungs, intestines, all those things tend to respond very poorly to high concentrations of electricity. And you'll also see a lot of times when these happen, in addition to the obvious thermal burns, you almost get like a coagulation type syndrome that goes along that pathway. The most recent two I saw were, like I said, linemen, and they were almost mummified from one arm to the other. We wound up doing just shoulder disarticulations on both of them because the extent of the injury was that bad. We talked about friction burns. They tend to be pretty minor, but you also tend to have associated injuries. So just be careful with those and be mindful because even though they're minor, they're extremely painful. So they may have a broken pelvis, arm, what have you, but the thing that's bothering them most is those friction burns that they've been laying on in the bed. They also have a very high likelihood of infection because oftentimes they're from contaminated surfaces, like I said, the road, things like that. Chemical burns, we talked about this briefly, but one of the big things you see is that it tends to have, in addition to like the topical injuries you see, you tend to have disruption of the cell membranes, which alters the pH. So a lot of times the initial therapy is not necessarily aimed at treatment of the burns as it is neutralizing whatever the solution is. So if you've got an acid, trying to make it more alkali and vice versa. So that's one of the big problems you run into there. You also tend to have very specific antidotes for the treatment of these things. So sometimes there is a specific chemical. Other times what you'll see is that we just dilute out the toxin or the chemical or whatever you encounter. One of the big things that people say is like dilution is the solution to pollution. Oftentimes in chemical exposures, it's very true. What we normally start off doing is brushing off if it's like a powder, get as much powder off as you can. Obviously, at the same time, you're trying to protect yourself. And then afterwards, you will usually irrigate it. But one thing you have to be cautious is some chemicals respond kind of violently to water. So just be careful with what you're kind of diluting things out with. Again, just like we saw before, a lot of times the extent of the injury is related to the duration of this exposure. And then something that's kind of specific here is that depending on the chemical itself, how it works. So, like acids tend to cause necrosis by coagulating tissue, whereas alkalis tend to kind of liquefy things. So, a little bit different exposure that results in the same end product of necrosis. Radiation burns, usually caused by direct ionization contact. Magnitude again depends on kind of the dose and time of exposure and then the type of particles. So when you're thinking about things for all these different types of burns, one of the big things that should jump out at you is that the extent of injury really depends on kind of the significance of it and then the time of exposure. The most common examples we see are like therapeutic radiation. So if you see somebody that's recently had radiation, a lot of times they'll have burns to the surface area where they're working. People that have had like diagnostic procedures done will sometimes have a little bit of a burn injury from the radiation. And then more commonly, what we think of is workers in the nuclear industry. Sunburns are also an example of this. They tend to be a combination of radiation as well as thermal burn. So classification of burns, we're going to kind of go through this. I would definitely make sure you remember not only what they look like, but what part of the skin is involved, because I think that's pretty important for you guys. It also kind of helps us evaluate therapeutic interventions. Somebody with significant first degree burns probably doesn't need the same interventions as somebody with third degree burns. So one of the things you'll see with burns is that very commonly they're not uniform. They're not uniform in depth. They don't tend to have like round appearances. They tend to be kind of jagged or irregular shaped. And then the other thing is that burns don't truly declare themselves for about 24 to 48 hours. So when you see somebody with a burn injury, it's never going to get better as far as like the burn percentage. So like if you look at them and you calculate they've got a 10% burn area, tomorrow it may be 15, 20. It's not that you were wrong. It's just that those burns hadn't fully declared themselves at that point. Other things you'll see that kind of the extremes of age, so age greater than 55 or pediatric patients less than 5, or those with kind of thin skin also associated with those ages, tend to have deeper burns in the same areas as like you or I would because their skin tends to be a little bit thinner there. So extremes of age, again, something we have to worry about when we start thinking about critical burns. So superficial or first degree burn usually involves only the epidermis. When you look at the skin, it's intact. There's no blisters. It tends to be kind of red. I think we've all experienced this before, and if we haven't, we've certainly seen it on somebody else. It's painful. It's extremely sensitive. You'll also see that it's not only sensitive to pain, but they also tend to have a little bit of temperature intolerance. So, like, they'll be very cold, they'll be very hot. That's okay. This usually heals on its own in about 3 to 6 days. One of the key things to remember with first degree burns is it's not included in the total burn surface area. So when we start talking about like fluid replacement formulas and those sorts of things, we don't include first degree burns in that. Second degree burns, which you'll also hear referred to as superficial partial thickness, because we can't say everything the same way each time. We try to make it as confusing as possible. But this is an example of a superficial second degree burn. Includes the epidermis as well as part of the dermis. It's red, it's mottled. Oftentimes, this is where the blisters will come in. Now, one of the things you may see is that they had blisters and they've either ruptured or dissipated, more often ruptured than dissipated. They tend to be extremely painful because all of the nerve endings are exposed at this point. So uncomfortable for patients, almost I think probably the worst because usually when you get to like third degrees, you've already burned off those nerve endings. So this is usually the most painful that I've seen. If you have significant second degree burns, they may require grafting and kind of extensive treatment, but not very often. Usually this is going to heal on its own after a couple weeks of discomfort for the folks. One of the things you do have to watch for these patients is that they're at high risk for infection at that time period. And usually when we're talking about patients with burns, we don't worry so much about antibiotics, but one of the things you do have to consider is the possibility of secondary exposure. So sometimes it comes from us. Maybe the patient in the OR before them had staph, C. diff, whatever, and then we transmit it to somebody who has an impaired skin system so they don't have that protective layer. So that can be problematic for us. This is just some other examples. Sometimes when you look at these, you can kind of figure out what happened. So like if you take a look at this lower foot here, You'll notice that it's kind of a circumferential ring. When I look at this, this appears to me to be somebody that probably stepped into hot water. One of the downsides, or I guess it's just something kind of sad, is that there tends to be a very high risk of non-accidental trauma in association with burns. So you'll see that children that are abused oftentimes have a burn component to it. Now they may be getting beaten, they may get smacked, whatever, but you will also see that they commonly have burn injuries. One of the common patterns you see is either being set into hot water or being dipped into it. So something like this, where the whole leg goes in. Like if you look at both ankles, they have burns there. Most of us don't jump into the bath with both feet at the same time. If you do, you're probably more coordinated than I am because I'm pretty sure I would fall. So when you see something like that where you have like bilateral circumferential injuries, be scared. Start thinking there's probably a non-accidental component to it. Other things you'll see kids that sit into hot water. Usually, if you're going to sit down in something, you put your feet in and then you sit down. So they're probably not going to wind up with their feet and their butt in there all at the same time. So again, kind of a scary pattern. And then the other one you'll see is cigarette burns as well. Just other examples that we were talking about. You will see these blisters appear for other reasons. Sepsis is a big one. You'll see a lot of times diabetic patients struggle and wind up with these kind of wounds, but just examples for you. Continuing on with second degree, these are deep partial thickness burns. So before we had superficial, now we have very deep. These are going to extend a little bit further into the dermis. One of the things you'll notice with these is they tend to be dry. So when we are talking about the superficial ones, we had blisters, they were very weepy. As we get further into the deep partial thickness wounds, a lot of times you'll see that there's not quite as much moisture. The good news is they're probably not going to lose as much fluid, but they have pretty significant injury. You also have to or tend to have a very significant color change. So if you look at this, notice how it's kind of pale or pink in color. Look back at these burns, we didn't have that discoloration. Notice how it's kind of red or weepy. So that's a big clue for you. There's usually decreased superficial perfusion. So like if you check cap refill, you'll notice that they tend to blanch and it doesn't change, or it takes quite a while to get color return here. Takes a long period of time to heal, usually 3 to 4 weeks at a minimum, and oftentimes requires skin grafting. If you take a look at this, you'll see that kind of the same thing I was talking about. You've got a pretty significant circumferential injury, and then you can only see the other foot a little bit, but there's pretty significant injury there as well. One of the other things you'll see is that when they get this grafted, oftentimes they tend to have like inability to control their temperature. So, for example, because that graft doesn't have the same structures through it because it's essentially been implanted, they get very hot, but they're not able to sweat. So a couple cautions we usually give patients that have significant burn injuries is one, you've got to be careful with your graft. So you'll see oftentimes even in summer that they're in gloves, so maybe wearing long sleeves, pants, things like that. So that kind of stands out as being a little bit weird to you. Part of that is to protect the graft, protect their skin, but the other thing is that they can't sweat, so they have a hard time regulating their temperature. They become overheated quickly. And this is just another example of it. Deep partial thickness burn. The one on the left, it's kind of hard to figure out what happened. Maybe they touched something hot. The one on the right, common time you'll see this is people that work in fast food restaurants. The grease from the fry cooker will splash up onto them, or I've even seen people that had a brain fart and dropped something in there and then went to grab it. So pretty significant and devastating injuries for those folks, but they usually do okay. Now, they will oftentimes wind up with either a scar from the injury or a visible graft. So when you start thinking about things when you're assessing patients, that's definitely something to look for. Problems we run into with those patients, it may be difficult to get vascular access through that area. Depending on how fresh the graft is, you may not want to go anywhere near it. But if it's a long-term graft that's well healed, you can certainly start an IV through it. Just be very careful with things like that. And then full thickness. Here you've destroyed the dermis, and what you'll see is that when you look at it, it's dry, painless. This is kind of what we think of a lot of times as a burn. It's kind of got that charring, especially around the edges. Non-blanching, it's not perfusing at all. The other thing is this oftentimes will require excision as well as grafting, and may take quite a while, like I was saying earlier, for things to kind of fully declare themselves. So this is an example for you. These are other examples. one of the problems you run into when you're trying to classify burns is it may be hard to figure out the difference between a full thickness and a deep partial thickness, like a second degree. The reality is, from our standpoint, it doesn't matter. We're going to treat them both the same. So back to fluid guidelines. Remember, we're going to include everything but those first degree burns in our fluid guidelines, so you don't have to worry about it. But these are a couple different examples for you. I think the patient in the top left was a thermal exposure, and then the one on the bottom right had something thrown onto them that was very hot. Something for you to pay attention, even though they're using an electrocautery here, if you look at that area where they're making that fasciotomy or escharotomy, you'll notice that there's no bleeding at all. That's because that tissue is already coagulated, so you have no microvascular perfusion. It's non-viable. This is just a chart to kind of help you out with things as far as like remembering what burns and kind of what things look like there. So now we're going to talk a little bit about how to estimate burn injuries. Were there any questions about identifying the burns? All right, cool. So when we estimate burn injuries, remember we don't include superficial stuff, so no first degree. The easiest way to do this is the rule of nines, and I will tell you there's a couple different methods out there. The burn centers tend to go a little bit more in depth than non-burn centers, but as I was saying, a lot of this is just an estimate anyways. So when you kind of get a ballpark idea of what's going on, it's not like somebody's going to come back and you said 49 and they say 51. That's not a big difference, because it does take a couple of days for things to kind of fully declare themselves anyways. So this is the rule of nines for adults. It's a little bit different for kids, and we'll talk about that in just a second. But the head is 9%. So the head's 9%. Each arm is 9%. Each leg is 18%. So if you think about it, we've got 18% for our arms, 36% for legs, and then the anterior and posterior trunk are each 18%. And then, as I was saying earlier, the critical 1%, the perineum. Because as you think about things, that's kind of a life long injury that may have some pretty significant problems for folks if it's not treated appropriately. Um, Issues with accuracy, it's only about 60 to 70% accurate due to various depths. That's fine. For our purposes, it doesn't really matter. It gives you a good starting point for things. When you're taking care of patients in the hospital that have been burned, somebody will have gone through and done a pretty detailed assessment of things ahead of time, so you don't have to figure it out. But it kind of varies from one facility to another. It also depends on where you kind of fall into this. Is this a burn patient that came into the emergency room at a little hospital and they want you to help with resuscitation? Or maybe you're helping to secure an airway and then you're helping with resuscitation. Lots of different things there. Um, this chart just kind of gives you an idea of what the rule of nines looks like. Now, when you look at the pediatric patient, you'll notice that because their head tends to be a little bit larger, that there's an increased percentage there. That's fine. You're just taking away from some of the other areas. But just remember when you're thinking about the rule of nines that for head on children tends to be a larger percentage. I would plan on being able to calculate burn percentages for your exam as well as for boards. It's kind of a common question. So make sure you remember the rule of nines. A little bit more accurate method of estimation is the Palmer method. So all you do is take the patient's palm, not your palm. Some places they will use cutouts to kind of figure out exactly what the patient's palm size is. Other places it's just a guesstimate. But with that being said, usually their palm is about 1% of their surface area. So if you're trying to figure out smaller burns, this may work out pretty well. Like I said, sometimes they'll take like paper cutouts of the patient's palm to figure this out. So just another technique you can use. Uh, so things that cause problems for accuracy of estimation, patients that have larger burn surfaces tend to be underestimated, which seems a little bit crazy. But again, back to the fact that those burns don't fully declare themselves, it can kind of make things a little bit more difficult for you. Other things that tend to cause problems, disproportionate body areas, because we're using kind of standardized patient. If you have somebody that has like a large breast size, they may have an increased surface area in their chest, or somebody that's obese. A lot of times, because their torso is a bigger portion of their body, we tend to underestimate those burn areas. And then at the same time, they tend not to have quite as large arms, so you'll see that a lot of times their extremities are overestimated. The actual location of their body habitus tends to influence things as well. So think about the different types of obesity and how that can kind of affect things. So burns can kind of be a conflict with each other, and the reason for that is that you tend to have two things that are battling each other. So you'll have hypovolemic shock that causes um, decreased perfusion, and at the same time, you have somebody that's essentially demonstrating all the symptoms of being fluid overloaded because they have peripheral edema, they have weeping blisters, those sorts of things. So kind of a conflict in terms. And what you see is as a result of the hypovolemic shock and decreased perfusion, that they tend to need extensive amounts of volume. But at the same time, they've lost the vascular structure. So you'll see that because of increased permeability, that plasma tends to leak out. Um, so kind of a conflicting thing. And we're going to talk a little bit about some strategies to manage those here in just a second. So when we start talking about the fluid losses, things you have to think about are what comes into play. So usually it's the patient size. Obviously, everybody's not the same, and then the extent of the burn. So that's why it's important for us to be able to calculate the extent of the burn, and then kind of have a good idea of the patient's weight as well. So if you have somebody that has a pretty significant, and when I say pretty significant, I'm talking about a 20% total body surface area burn injury, they probably need to go to a specialized center. We're going to talk about some of the burn center referral criteria, but oftentimes patients with those kind of significant burns need to be pretty well managed. If they don't go to a burn center, you'll see that a lot of times there's kind of like burn center light, where they'll take care of kind of more minor burns. And you're seeing that more and more folks, instead of going to kind of traditional burn centers, are opening up burn clinics and burn practices in non-burn center trauma centers. So when you start thinking about this, it's really a balancing act. Um, and for a long time, we didn't truly understand what we were doing. We would over resuscitate everyone. The good news is we thought, we met all the numbers, but it was almost like treating blood pressure in patients. We made things look pretty, but the patients didn't turn out very well. So one of the problems you run into if you under resuscitate patients is obviously they have decreased volume status, they have decreased perfusion, they tend to have shock as a result of that, and ultimately they wind up with end organ failure. Particularly kidneys tend to be very sensitive, not only because of the decreased perfusion, but also because they tend to be the filtering element to filter out a lot of the contaminants. One of the biggest ones we see in burns is that they tend to have large amounts of myoglobin that spills into their kidneys and causes a mechanical obstruction. So they can be kind of struggles from that standpoint. The other thing, and this is the one we didn't think about for a long period of time, is what happens when we over resuscitate these people. Um, Oftentimes, they're not young, healthy people. They can have comorbidities that obviously increase the morbidity and mortality. Big things we have to worry about with those folks is maybe they already have a touch of CHF or cardiac insufficiency, and now we're giving them large amounts of fluid. They may not do very well with that, so we've got to be cautious there. But one of the big things we didn't think about for a long period of time, and this isn't necessarily restricted to burns, we see it in a lot of other patients, is abdominal compartment syndromes. And what we would do is we would give these patients tons of fluids trying to save their kidneys, but all that fluid has to go somewhere, especially if the kidneys aren't working. And what we found is that we had a lot of bowel edema. That bowel edema then led to abdominal compartment syndrome, and now on top of their burn injury, they've got a dead gut. So we'll talk about it a little bit more in a second, but one of the things that we've kind of accepted is that we will do adequate initial resuscitation, but at some point we may just have to stop and say, hey, I understand the kidneys are going to take a hit. So instead of flooding this patient and killing their lungs, killing their gut, I'm going to go ahead and move them to CRRT very early so I can save their kidneys. And then I'll go ahead and worry about the fluid situation that I haven't created. So that's kind of a more current trend for treatment of burn injuries. So we see some other things that happen that we don't necessarily think about in patients that have burns. One of them is just kind of a general metabolic response. So what you see is that the body essentially starts to eat itself. So you'll see that we tend to lose fat, we tend to lose a lot of our lean body mass very quickly. So when you start thinking about these patients, one of the biggest changes we've seen is that we try and start getting them some sort of nutritional support early to help prevent this. It's still going to happen. A big part of that is due to this kind of hypermetabolic state they go into. And we'll talk about some of the physiologic things that associate or follow along with that as well. But they can be very challenging from kind of a medical standpoint as a result of this. So it's not only about nutrition, we also tend to see even in young, healthy people that they will develop insulin resistance very quickly. And this hypermetabolic state will continue for some time. Things it's dependent on. A big part of it is the sympathetic insult that the patient takes. So I can't do much about the burn. The injury has already happened at that point. I can treat it. But one of the big things we can address is the degree of their pain, because that tends to be one of the biggest driving factors that we can modify in terms of their metabolic response. So in addition to the obvious discomfort that goes with pain, there's some other things we encounter as well. So one of the big ones is kind of this metabolic response where they go into this cannibalistic state for a while. It depends on which source you look at, how long it is, but a lot of times you'll see that it could be 4 to 6 months at a minimum. Other things you see, as I was talking about, your metabolic rate increases. If you have patients with even more significant burns, so we were talking about 20% when you start thinking about going to the ICU, you start talking about patients with like 40% BSA burns. This goes on for quite a long time. Those patients, oftentimes, you'll see it continues up to years. So things you have to think about from that standpoint are not only this kind of metabolic issue we're dealing with, but other things that go along with it. One of the big one is immunodepression. And so you take somebody that's immunodepressed and then you expose their kind of inner core because they don't have the ability to protect themselves from a lot of those surface infections. And it's a really bad combination for those folks. So from a carbohydrate standpoint, what we see is that there's an increase in cortisol, catecholamines, and glucagon through that hypermetabolic state. And when that happens, you see that we have accelerated gluconeogenesis in our liver. Again, talking about kind of increased insulin resistance in these patients. And this can go on for quite a while. It does tend to be related to the extent of the injury, but we're talking about something that can go on for 2 to 3 years. So even in young, healthy people, you may see that they have a diabetic-like state for several years following this injury. From a lipid standpoint, you have an accelerated lipolysis, which occurs as a result of kind of the sympathetic stimulation. And as a result of that, you have increased levels of cyclic AMP, glucagon. So what we do as part of the treatment process, I told you there were some things we could do to kind of modify this. So we try to control pain. But the other thing is you'll see a lot of times these folks will get started on a beta blocker very early on to help with that out of control sympathetic stimulation. Um, so you'll see that they may be on like a low dose of atenolol or something like that. That's something we need to consider for our anesthetic plan because now they may not be able to respond to things like hypovolemia or hypotension in a normal manner because we beta blocked them. So just be cautious with that. From a protein standpoint, we tend to see that there's pretty quick wasting of the skeletal muscle. So we try to get PT involved with them early on. PT is generally not something we have to worry about, but in these patients, you will because if they're in pain and they can't do things, then they're not going to be able to participate in PT. So you may see that you get a consult for somebody because they're trying to increase their participation level. If it hurts, they won't move it or get out of bed. So those are something for you to consider as well. So what do we do with these folks initially? The good news is it's very similar to everything else. You start off with your basic ABCs. Respiratory support's one of the main ways we wind up getting involved with burn patients. So they have a high likelihood of burn injuries, so we need to secure an airway. And we'll talk about those a little bit more in detail in here in a little while. Other things that come into play, fluid resuscitation, as we talked about, is a big part of this. So appropriate and kind of intensive initial resuscitation with fluids. And part of that may go along with cardiovascular stabilization, or what you'll see a lot of times is these patients, especially as they get a little bit older, have other comorbidities. So you may be dealing with other factors. They had demand ischemia because of the volume loss, and then they had an MI. So now we're trying to help out with management of that. And then the last two here are something that's a little bit more specific to kind of select populations. So as far as pain control, a lot of times that tends to be our wheelhouse. But you'll also see that burn surgeons are pretty aware of management of pain control. And sometimes they may use different treatment modalities than you would. That's okay. Again, going back to last week, have a conversation, talk about things, and then local care of burn wounds. It's kind of weird, but what you'll see sometimes is patients will be referred from an outlying facility for burn treatment. And then instead of going to the burn unit or burn ICU, they actually just go to the clinic and they do fine there. So you may not necessarily see all these patients going into the burn unit or the ICU. You may be doing some of these things in clinic. So secondary priorities continue pain control because that is one of the biggest devastating complications of this, and it's one of the biggest things we think about too. So it's kind of easy to remember. Thromboprophylaxis is important for these patients. Oftentimes, because of their injuries, you'll see that we're limited in our mechanical abilities, so we may not be able to put something like TED hose or SCDs on. So most of these patients will go on some sort of pharmacoprophylaxis, usually a low-dose heparin or Lovenox. This is a gradual process. They're not magically going to get their burns fixed in one day. So you'll see that oftentimes, even after they're discharged from the hospital, they'll come back for wound closure, continued wound support, those sorts of things. It's also a very multidisciplinary process, not only including us, but other things to think about, folks like nutrition, counseling, because there is such a strong psychological component to this. We try and get them involved very early. There's also the circumstances around the burn and the fact that you may not only have one burn patient, but it may be multiple people. So sometimes, especially if the patient you're taking care of is the one that caused the situation or is responsible for it, there's a huge psychological burden for them. Long-term control of that hypermetabolic state that we talked about is extremely important. So you'll see that oftentimes these patients go home and they have to continue like a high protein diet. They may also continue the beta blocker. And then one of the other concerns that we run into is that there's still a high risk of infection as long as they kind of have that impaired skin integrity. Other things to talk about that I kind of touched on here. Secondary priorities may be somewhat dictated by what's going on with the patients. Very rarely do we see that it's an isolated burn injury. So it may be a burn injury with a toxic exposure. It may be a car accident with polytrauma. So sometimes you have competing priorities for these patients. So for instance, you've got somebody that's got a head bleed and burns. Obviously the burns are difficult, but so we start thinking about treatment there. For burns, I need to give lots of fluid. If I've got somebody with cerebral edema, that may not be a good idea. Same thing when we're talking about like mechanical prophylaxis for these folks. I may have to go to mechanical prophylaxis because I can't do any sort of pharmacoprophylaxis because of their head bleed. So you can see how quickly those things kind of become conflicting priorities. So as far as pain management, most of these patients will go on scheduled long-term or long-lasting analgesics. For a long time, opioids have kind of been the go-to for that. What we're starting to figure out is that you will probably still need opioids, but you can supplement those with other things. And a lot of times, those other things are not necessarily what we truly think of as pain medications. So, obviously, Tylenol is a pain medication. Putting them on a PCA gives them a little bit of control. Ketamine, we tend to think of as a sedative, but it also has great benefits, especially in these patients from a psychological standpoint, but also from a pain standpoint. And then the recognition that we get a lot of synergistic effect with other medications we use. So instead of just using like true pain medications, we may put them on a low dose benzo. And then also long term, we're starting to see things like gabapentin may offer some promise for kind of long term neuropathic pain as well. You may see that because of the altered volume of distribution that their PK and PD has been differentiated. So you'll give a patient a normal dose of a medication and get a pretty extensive effect. Or because of that hypermetabolic state they're in, you may need to actually give more medications. There's kind of hard to figure out exactly where they fall into that kind of continuum. If we're giving medications to these patients, we tend to try and do it IV, especially in the initial period. IM medications, even in non-burned areas, may not be reliable. So IV is our preferred route. Over time, you can consider using PO stuff if possible, but in the initial period, you want to do IV. So after burns, fluids are one of the biggest problems we run into. So the big thing you encounter is that they've lost their ability to maintain fluid in their intravascular space. So they suddenly have increased capillary permeability, and as a result of the loss of intravascular oncotic pressure, you see lots of fluid weeping out of those vessels. Initially, it starts off as edema. After it's been edema long enough, all of a sudden you're going to see that they start to have kind of these weeping wounds or sores. Other things you'll see at the same time, and this can be systematic, it's not necessarily just in the area of the burn, but they have a huge histamine release and a huge release of prostaglandins and cytokines. So when you see that happen, that's really kind of the driving force for where this fluid loss happens. So sometimes we'll do things like give low doses of antihistamines early on to try and prevent that. May also give low dose antihistamines early on to try and work on stress ulcers as well. So for fluid needs in these patients, the actual number depends on kind of the burn area. And one of the things that we run into is that sometimes we underestimate things. So what do you guys think the surface area of an airway or a trachea is? Any guesses?
30
Like
centimeters
2%?
squared.
5%.
So it's kind of a trick question. So you breathe in superheated gas, whatever the toxic contaminant is. Where does it go after your airway? Into your lungs, right? If you actually look at the surface area of the lungs, depending on which source you use, estimates are usually about the size of a tennis court, which makes sense when we start thinking about all those little tiny overlapping structures in there. So one of the areas that tends to be underestimated as far as fluid resuscitation is pulmonary burns, because you don't have a physical calculator for it. There's no lung surface area calculation. It's just body surface area. So you may have somebody that just has an airway burn, but because of that pulmonary involvement, it's actually a lot more extensive than it appears to be. So when we start talking about kind of critical burns, and it depends on the source, you may see 15 to 20% as kind of a good reference point. But again, you may have somebody with like one of those critical areas like airway burns, perineum, those sorts of things. But airway burns tend to be one of the biggest fluid issues we run into because we don't account for it very well. The other problem is because you've had a direct pulmonary insult, you'll see that a lot of times those lungs will start to weep on their own. So now you've not only got the issue of the direct trauma from the burn, but you also have the secondary problem you run into with pulmonary edema and direct issues. So they can be very complicating for us. So IV fluid needs may be driven by your patient, not necessarily what you're seeing. So how do we figure it out? A lot of times we start off with a standard formula, and we're going to talk about a couple of them here. But the second part of that is you kind of have to let the patient show you what's going on. One of the biggest things that we look at is urine output. But if you've got somebody with myoglobinuria, you may not have any urine. So you may have to do other kind of calculations of volume status, things like looking at the IVC. Sometimes we'll put in a central line and look at CVP in these patients. Some places think that's great. Some places have shied away from it. There's not a magic answer for a lot of this, so we just talk about different approaches to treatment. So one of the most common formulas you'll encounter is the Parkland formula from over in Dallas. The funny part is Parkland doesn't use the Parkland formula anymore, and neither do a lot of major burn centers. But this is probably the most commonly accepted burn formula out there. So what we do is kind of figure out the patient's weight, the burn surface area, and then multiply the two of those, and then multiply it times 4. So, for instance, if I've got a 50-kilogram person that has 50% body surface area, I'm going to do 50 times 50 times 4. So I come up with 10 liters. And then what I'm going to do is divide that in half. So I'm going to give 5 liters over 8 hours. So 5 divided by 8, or 5,000 divided by 8, gives me an infusion rate of 625 for the first 8 hours. And then over the next 16 hours thereafter, I will continue that. So it's basically going to be 625 for the first 8 hours and then cut that in half for the next 16. Now, this is a starting point for us. Things you need to consider with this is it starts at the time of injury. It's not the time the patient gets to your hospital. You also have to take into account what they have or have not gotten at that point. Sometimes people do a really good job with initial resuscitation. Sometimes they overdo it. Sometimes they underdo it. So you may have to kind of adjust where you're at depending on what they've already received. Down in San Antonio, the Army has their burn center at the Institute of Surgical Research. They use a rule of tens. So for adults, it's 10 mLs per hour times the total body surface area. If you have somebody over 80 kilograms, you're going to add 100 mLs for every 10 kilograms. Pediatrics, you start a little bit lower. So 3 times the total body surface area times kilogram is your volume for the first 24 hours. And then from that standpoint, it's essentially the same as with Parkland, where you give half over the first 8 hours and half over the next 16. Do you guys have any questions about that? Because that's kind of an important topic for us to understand, because you will see that multiple times in the future. All right, cool. So from there, we're going to kind of transition over to anesthesia management of patients. This is obviously a pretty extensive burn injury. Um, Unfortunately, pediatric patients tend to receive a lot of these, either because of non-accidental trauma or because of kind of circumstances like motor vehicle accidents, not necessarily poor decisions, but maybe poor actions. They're out at a campfire and somebody thinks the fire's a little bit low, so they pour some gasoline on. The adults are like, that looks bad. They get back. The kids tend to be a little bit more trusting. So that's a big one we see, is people pouring flammable liquids onto something that's already burning. Other things we'll see, people lighting matches in gas-filled environments without realizing it, or maybe not necessarily lighting a match, but some sort of spark that ignites that. On the same note, not necessarily the same way, another thing we see is meth labs. So meth labs will explode and people will wind up with widespread burns. So if you hear about a gas explosion in a trailer in the middle of the night, it's probably not actually a gas leak. It was probably a meth lab cooking off. But I do know, especially as we're starting to see a lot of our infrastructure get older and older and older, that we do have kind of big gas explosions, multiple fatalities, pretty significant burns that can happen as well. So as far as anesthesia management goes from a pre-op standpoint, so think about the basics, figure out the burn surface area, the severity of the burn. And then this is the big criteria we talk about as far as patients that need to go to a certified burn center. So if you have somebody with full thickness burns over about 10%, electrical injuries, if they're significant, will almost always need to go there because they're very complicated patients. Extensive chemical burns may need to go. Extensive, generally the rule I use is anything that I can't put in a bucket is probably going to need to go be managed there. Inhalation injuries almost always need to go to a burn center. Now, sometimes what we see is what we think is a burn injury, and upon further assessment, it's not. So, for instance, you have somebody that was exposed to a fire. Obviously we can't start off looking down in their trachea, so we look at kind of basic symptoms, singed nasal hairs, things that make me think that their face was exposed to high temperatures. So we may assume those patients have an inhalation injury, start treating them as such, and then it turns out later they didn't. We're always better to overtreat those patients versus undertreat. And then critical areas. So things like face, hands, feet, perineum, major joints, things that could definitely have an impact on your quality of life if they're not managed appropriately. Those patients need to go to burn injuries as well. So assess the fluid resuscitation. Like I said, the two big ones we look at are Parkland or ISR. but you may see that there's some variability. When we get towards the latter half of this presentation, we're going to talk about some other kind of supplemental treatment guides that are out there now that focus on things other than just crystalloids. And one thing for you to remember, no matter what you're doing, your overall goal as far as urine output goes for these patients is going to be 1 ml per kilogram. Be careful about fluid. Remember, it comes from all sorts of other sources. So it's not necessarily what you're just giving as a fluid bolus. If you're hanging antibiotics, you're pushing medications, all those things also are giving fluid. So just be real careful with it. Kind of the fluid of choice for a lot of these patients is going to be LR or something isotonic. We avoid saline for most of these patients because there is a risk of hypernatremic, hyperchloremic acidosis. Most folks are going to reevaluate this at a minimum of every 30 to 60 minutes. So if you're not going further than an hour, you probably need to fix your practice. And what I mean at that point is you're going to stop, see what your urine output was for that hour, and then adjust. We tend to be a little bit slack in anesthesia about checking our urine output. So just try and stay on top of it. This is something you really need to be doing every hour, not every so often. If you have patients that are getting large amounts of crystalloid, you may need to think about other options for them. So some of those patients, what we'll consider is doing something like continuing crystalloid, but instead of increasing our crystalloid rate, we may supplement with albumin. And like I said, we'll talk about some of those strategies here in just a little bit. Pediatric patients, kind of a cutoff here is if they're over 40 kilos, go to the adult version. We can put ages on there, but with kids, it's kind of hard to figure out exactly where they fall in that. One thing to remember with this is make sure that you're also giving pediatric patients some sort of maintenance fluid with dextrose in it as well, because we need to meet those nutritional needs. So this is kind of a strategy for college for these patients. And the suggestion from this source was 8 to 12 hours post burn. If you're hitting more than 1,500 mLs per hour, or if you're going to, over a 24-hour period, wind up giving more than 250 mLs per kilogram, consider starting albumin for these patients early on. And this is just an example of a dosing table. There's lots of different strategies out there, but you're just giving 5% albumin for these patients. I think this is pretty decent strategy to follow, and you see that a lot of the newer guidelines kind of follow this. So definitely something to consider for your practice. And we're talking about burns here, but the other thing is that there's a lot of times that you can use these strategies for other people that need volume resuscitation. For pediatric patients, the colloid dosing is just a little bit different. They suggest 4 to 7 mLs per kilo at a rate of about a half ml per minute. Again, there is some variability there with kids. The good news is that we don't have a whole lot of kids to experiment on or research on for burns, but that is something to think about for the future. So we experience kind of a weird thing that goes on as far as the cardiac status in burn patients. So you have kind of an ebb and flow state. So in the initial resuscitative phase, a lot of times what we see is our cardiac output is very low. Part of that is due to hypovolemia. Remember, they've had all that volume loss as they leach out, and they tend to respond poorly to things. So you'll see that you give a catecholamine like epinephrine, and they may not respond very well. The other thing you see is not only do they have hypovolemia, but they also have kind of increased SVR. So as a result of that, and then it's initially trying to compensate, you tend to have the kind of profound cardiogenic shock, if you will. So if you have somebody that already has coexisting cardiac issues, you have to be very cautious because they're at high risk for having myocardial ischemia. So make sure that you're giving those folks enough fluid resuscitation, but not too much. You may also see that to try and prevent part of that fluid leaching, oftentimes we'll start these folks on like a low dose peripheral vasoconstrictor. And then the flow phase, when everything kind of starts catching up, usually 3 to 4 days after the burn, what you'll see is that they go into kind of this hyperdynamic state. Their heart rate goes up, they become tachycardic, their cardiac output recovers. But as a result of that, they have a huge increase in the myocardial oxygen consumption. So the patient that had an MI on day one because we didn't adequately volume resuscitate them now has a heart rate of 120, 130. and they're going to have profound ischemia. So be very cautious. If we haven't started patients on beta blockers already, we always do it at this point to try and prevent this from happening. So sometimes to avoid kind of shooting ourselves in the foot, we won't start it during that initial 24 hours and just do pushes. But with these folks, you're going to need to do something a little bit longer lasting after that initial period. Other things you see, we talked about this earlier. This big systemic inflammatory response usually starts right after the burn. As a result of that, you're going to have pulmonary hypertension, but you're also going to have decreased plasma oncotic pressure. So as a result of that, you have a lot of weeping out into the lungs. So pulmonary edema is very common. We also see that these patients, as a result of this, are at high risk for bronchospasm. So almost all of our burn patients are going to go on some sort of bronchodilator therapy, usually albuterol, but sometimes we'll do Atrovent as well. So that's something else for you to consider, especially in the perioperative period, is that these patients may need a neb treatment if they haven't gotten one, and you may need to puff them a couple times before you wake them up as well. Something else you may see in this, especially in extensive thoracic burns, is a restrictive lung defect. So what I'm talking about here is a physical impairment. You can't ventilate this patient because they've got circumferential burns to their chest. So as a result of that, you've had swelling, and now there's physically no room or no mobility for the lungs to expand. So you may have to mechanically ventilate those patients. It's almost like somebody for a double lung procedure to increase your rate and decrease your volume, but they may necessitate escharotomies as well. So some specific things talking about inhalation injuries and airway burns and facial burns, because as I said earlier, this is one of those times we really tend to get involved with these because they can be very tricky airways. So when we think about things that are going on, we often think about people being out in kind of open areas or like house fires and stuff like that. But if you think about somebody that's trapped in a bedroom that's been on fire, or they're in a car, either because of chemical impairment or physical entrapment, they may not be able to get out of that space. So think about somebody that's been in a car accident and then there's a fire. Or think about somebody that's wheelchair bound and they can't get out of their bedroom because they physically can't move. So those folks may have prolonged exposure to some of these things. And as a result of that, you may see some of these inhalation injuries. So like I was saying, big things we look for, singeing of the face or nasal hair. So like you look and they don't have eyebrows or eyelashes anymore. Maybe they have a beard or a mustache and you can see where that's burned. Those are big things. You may actually look and see that they have kind of black tracks or soot coming out of their nose where they were burned and they were breathing in those superheated gases. If you open their mouth and look, you may see that their tongue is black, that they've actually breathed in that carbon. From a lab standpoint, you may check and they've got a carboxyhemoglobin level that's greater than 10%. So that's something for us to make sure we remember, especially in the acute treatment of these burn patients, that if we're getting an ABG, make sure we're also getting a carboxyhemoglobin level as well, because that will not show up on our routine monitoring, and it may take a little while to correct. Other things you'll see, wheezing is pretty common, especially if they've kind of had a terminal pulmonary injury to the point where it's down to the alveoli. And kind of the definitive confirmation for this is that we wind up doing a bronchoscopy. It may also be the intervention for these patients, and we'll talk about that a little bit more in a minute. So facial burns can be kind of grotesque, for lack of a better word, but from our standpoint, they can also be very difficult because you've got kind of the perfect storm here. You have a whole lot of tissue that becomes swollen, but you also have a whole lot of tissue that loses mobility. So somebody that was a perfect grade one view before now has a big swollen baseball head, and because of the loss of mobility, maybe they can't extend their neck or open their mouth. You will also encounter patients that have significant facial burns to the point where tissue will fuse together, so they may not be able to open their mouth at all. So something for us to think about with these patients is how are we going to secure endotracheal tube? It's common to use kind of twill ties to secure it. Those generally go circumferential, excuse me. Tape won't work because their faces are weeping, it's burned. The other thing you'll see is it's fairly common to suture the endotracheal tube to the patient's mouth, lip, what have you, to retain it that way. Other things to think about, we're always worried about the eyes, but also think about patients that may have contact lenses in place. If you have contact lenses, you know how friable they are. So if you can imagine being exposed to heat that's significant enough to burn you, what it's going to do to that thin little layer of plastic. So ocular injuries are pretty common in these patients. Just take a look in their eyes if you can. You may be the last person that has a chance, and then we figure out, days to weeks later that they had eye injuries. You will see that ophtho is commonly consulted for patients with facial burns just to make sure the eyes are intact. We put bacitracin on the eyelids. We put erythromycin in the eyes. The common ointment we use for burn injuries is Silvanine. We don't put that on the face, so it's just bacitracin on the facial skin. Um, Not that it's something you commonly have to do, but it is something for you to think about. Carbon monoxide. So kind of think about those situations we were talking about, people that are in confined spaces. You're going to breathe in a whole lot of nasty stuff. So if you think about somebody that's in a house fire or a car fire, when we think about fires, we think about like clean burning wood. Not that, it's good to breathe in that smoke either. But a lot of times these people are exposed to other things. So carbon monoxide can easily be produced by things like fuels. But what you can also see is that things like plastics burning produce cyanide. So now you've got somebody that not only has, this burn injury, but they've also got cyanide poisoning on top of that. So you may need to treat them for that at the same time. Just something for you to remember, because we get kind of focused on just the burn injury, but there may be lots of other things that come into play. This is a good chart for you to remember. There's like little charts that they love to throw at you for boards. One is like the magnesium level and the loss of deep tendon reflexes. This is another one you'll see is the carboxyhemoglobin level and the symptoms associated with it. So something for you to think about here. We said over about 10% is when we really start to see signs and symptoms. So if you think about it, most folks that smoke pretty heavily, which fortunately is not so common anymore, are almost at that 10% already. So we touched about this earlier, but one of the big reasons I put this slide in there is we're real good about making everybody NPO when we take them to the operating room, but these burn patients are going to be going to the operating room sometimes twice a day. If I make them NPO for 8 hours before I take them for a procedure, they may only be getting 4 hours of nutrition a day. Not enough for somebody to heal, especially when it's somebody that we're already worried about their stress response, that hypermetabolic state, that increased nutritional demand. So a lot of times what we'll do in these patients, if they're not able to take PO on their own, and sometimes even if they will, just to supplement them, is we'll go ahead and put a nasoenteric tube in and start feeding them into the jejunum. So that way we're at decreased risk for aspiration, but we can also get kind of some sort of nutritional supplementation in there without having to cancel it every time we turn around. We touched on this earlier, but from a pharmacologic standpoint, think about changes in plasma protein concentrations, especially early on with albumin. So we need albumin to carry a lot of our medications. But if we're having a lot of that plasma loss, we may be losing the albumin as well. So another benefit for giving that albumin earlier on. Other things we tend to see, and we'll talk about it in just a second, but acetylcholine regulation tends to go out the window in a variety of different ways. And some of it can be very short acting, some of it may be very long acting. And then think about where they are in kind of that ebb and flow pattern of their cardiac output. Are we very early on, or are we a little ways out in things? So, from an acetylcholine standpoint, it can take years to recover. And one of the biggest things that we see as far as like an anesthesia concern in these patients is use of a depolarizing neuromuscular blocker like succinylcholine. So what you'll see is these patients have a significant increase in their serum potassium at baseline. And then if we administer succinylcholine, obviously it increases even more drastically. One of the weird things with this is it seems to be tied more to the burn physiology than necessarily the significance of the burn. So like everything else we talked about was really tied to like duration of exposure and significance of burn. This doesn't seem to be that way. You may also see that they have a pretty marked resistance to non-depolarizing agents if they have a significant burn. So you may see that you have to give those patients even more neuromuscular blockers to achieve the same result. And this can go from days to years. So just because somebody is, 6 months to a year out of a burn doesn't mean that they'll have normal receptors. So things for us to think about from an anesthesia standpoint as far as like monitoring. Our monitoring standards don't change just because you have a burn patient. But what you may have to consider is like functionally, how do you apply things? So if I've got somebody whose chest is weeping and I put an EKG sticker on there and it doesn't stick, it doesn't mean I can skip the monitoring. I just have to think about a different way to do it. Sometimes we can move the electrodes to a different part of the body, but what if the whole chest is burned, shoulders are burned? Something else that's kind of common practice is that we will put staples into the skin. And then instead of using traditional EKG electrodes, they actually have alligator clips that you can clip onto those staples to monitor. So that's an option for you. Other things to think about, like a pulse oximeter, if I've got a burned extremity, it may be uncomfortable or it may not read, so I may have to move it someplace else. And then the other thing is, especially with like CO and carboxyhemoglobin levels being potentially impaired, how accurate is our pulse ox? It may not be, so that's something you have to think about as well. Non-invasive blood pressure cuffs may be a possibility, but you'll see very commonly in these patients, especially during the acute resuscitation phase, we're going to put in arterial lines. And these arterial lines are going to be sutured in place, as almost all our lines will be, even IVs, because they tend to have such significant fluid loss that everything in the bed gets soaked. So tape isn't going to work, tegot arms aren't going to work. So we try and suture those things in so they don't mobilize on us. Things to think about for your ABG, be very mindful of your base deficit because we have significant volume losses in these patients. So it's a good trend to kind of follow how your resuscitation's going. Something else that might be beneficial for you, especially in kind of that first 4 days, stroke volume variation may be helpful as well. This can't get understated or overstated enough. Temperature management in these patients, because of the impaired skin integrity, they cannot regulate their temperature at all. So what you'll see is they can lose up to a degree Celsius every 15 minutes. So that's a pretty significant change in an hour. So physically, the burn units tend to be very warm. The patient's rooms tend to be very warm. The OR tends to be very warm. So if you happen to be rotating through the burn unit, remember it's going to be hot in there. You're going to be sweating like crazy. So think about what you're wearing, kind of how you layer stuff, things like that. But also think about what you're doing to expose the patient. So when you take them to the operating room, try and keep everything as covered as possible. You don't need to necessarily expose the patient. Another area we run into problems with is transporting these patients. So in most of the kind of the dedicated burn centers, you'll see that they have an OR in the burn ICU or the burn center. But in some of the smaller facilities, you don't have that option. So you're just using a traditional OR. If you're taking that patient from the ICU or the burn unit to that OR, keep them covered up because we all know how cold and nasty the hallways can be. We don't want them infected. We don't want them cold. And then make sure you're trending the urine output. Even if these patients don't have a Foley, they may need like a Texas catheter or something so we can keep accurate control of their fluid ins and outs. So when we start talking about airway assessment, this is kind of a common picture you'll see. So when we look at this guy, there's a whole lot of different things we can see. If you've never seen burnt hair before, this is what it looked like. It's almost like if the hair was kind of the consistency of plastic, and when you heat it up, it curls up and kind of gets a clump on the end. So if you look up on his forehead, you can see up here his hair is singed there, coming down to his face, on his beard and mustache, I see it singed. When I look at his nose and right there around his maxilla, that's that singed tissue I'm talking about. So those are the things that I really worry about somebody having a significant inhalation injury. Other things that are kind of obvious here, or concerns here, when I look at his face, I've got that singed area. It looks like maybe I've got a blister already forming on that cheek. But something else you'll see is that they'll have like carbonaceous sputum. So like they're coughing or they're spitting up stuff. And most of us don't wake up or, at any point in our life, spit up like black sputum. So if they're spitting up or coughing up black sputum, that's a pretty significant concern that they've probably had a potential injury inside their lungs as well. So things to think about there. Obviously, the patient's had an airway injury. I'm a little concerned about that. But the other thing is, how am I going to manage this airway? So one, we want to try and take the airway early, but it's almost like a known difficult airway. When I look at these patients, I'm anticipating the worst. And if you do that, you'll be okay. But this is somebody you probably want to have the fiber optic scope available. You probably want to have a glide scope available. You may need to have, depending on the kind of patient's body habitus, you may need to have surgery on standby for a surgical airway. And if you do all those things, you tend to be okay. It's when we kind of go into it from a cavalier standpoint that we have trouble. So this is what you may see on the inside. And this is part of the reason I said to have that fiber optic scope available. Because if you look at those pictures A and B, you'll notice that I can pretty clearly see the epiglottis. I can kind of see the trachea in the first image a little bit. But by the time I get to that second picture, there's really very little I can identify other than that swollen epiglottis. So trying to put a tube in there may be very difficult. Sometimes in these patients, what you can do is use like a bougie as an introducer. So thread your bougie down through that and then advance the tube over top of it, but very challenging. The top right images are what you're probably going to see on bronchoscopy. So if you stick a scope in there, this is obviously somebody that's breathed in superheated gases. I can see the carbon buildup inside the bronchus themselves. And then the other pictures are just after lavage and then a couple of days of progression. So you notice over time, kind of that charred appearance goes away and you're just left with a red surface. These are just some different airway pictures you may encounter. And I don't do this to be gross. I don't do this to scare you, but I think one of the hardest things for us to deal with sometimes is the moment of the situation. So you get called to the ER, the ICU, and they want you to intubate somebody, and you walk in and see this. It's distracting. We're worried about their sympathetic drive, but what about us? This is something very hard to deal with. One thing I've done in the past to kind of make me feel better and to take away from kind of some of what I was dealing with there, I've put a surgical towel over the face while I was intubating before. Obviously, not to the point where it affects the airway, but to the point where I don't necessarily have to look at everything that's going on there. So just something for you to think about there as well. So some tips for airway management in these patients. We're going to start off talking about, why do we need to take this airway? Well, we looked at all the pictures, so that's pretty clear. But what about other signs and symptoms? So somebody with stridor, hoarseness, difficulty talking or swallowing, big indications they're probably going to lose their airway quickly. The airway will never be better than when you first see it. So, how I talked about it takes 24 to 48 hours for those burns to fully develop. The whole time that's going on, we're going to have swelling. So what we want to consider is that the edema will only get worse. Other things you may encounter is that edema develops. They may have inability to move. Contractures and eschar are what we really worry about. But what if this is somebody I'm doing an awake intubation on? If they're in pain, it may affect their positioning as well. So just be cautious of kind of how you address those folks and have a very low threshold to intubate them early. If you intubate them and they bronch them and it turns out they didn't have any sort of pulmonary injury, that's great. If you wait and you wait and you wait, you may not be able to get the patient intubated. Other things you'll encounter, and this is kind of what I was discussing as far as like the facial stuff. Sometimes they will have burn dressings or like burn gel dressings that sit on their face. You may have to take those off to be able to get a good seal there. It also makes everything difficult because of fluid loss and edema. There may be some weeping there. So you may need to wipe the face off as well to try and get your mask to sit on there. If possible, preserve spontaneous ventilation in these patients. This is a known difficult airway. So if you're able to get into it without causing problems for yourself, that may be an option for you. So if you can just sedate them and topicalize the airway, that may be a nice option to do instead of giving them a paralytic early on. Other things to think about, I told you that tape tends to not work very well. Umbilical tape is kind of our go-to, but you may also see that the tube is sutured or wired to the teeth as well. LMAs tend not to be a very good option for this patient population, but if you have an emergent airway, an LMA that works is better than an ET tube that doesn't. So don't discount those, just don't use those as your primary airway. Medication-wise, we really have to think about where we're at in that ebb and flow state, as well as the other kind of patient conditions that are going on. So when they're in that hyperdynamic phase, propofol may be a good option for you. But when they're in that kind of early low cardiac output, propofol is not a good choice. You think about it, they've already got a relative hypovolemia. The last thing we want is something that causes vasodilation, hypotension. Etomidate is go-to for a lot of these, but we have to be cautious because we know that etomidate causes adrenal insufficiency. And somebody that really needs that cortisol, that may not be a good choice for them. Ketamine may be beneficial for them. It does offer some sort of, some treatment of pain, but what is their sympathetic reserve? So that's something to think about for you as well. You will see that ketamine is used pretty widely and in pretty large doses for these patients for like dressing changes, and it may be done at the bedside by the ICU nurse. They may not necessarily go to the OR. And then opioids, we talked about earlier, kind of the go-to for pain management for these patients. But again, look and see where they're at in kind of that ebb and flow phase. If they're already hemodynamically unstable, might not be a good choice for you. Um, when we're talking about that hemodynamic instability, um, one of the things that we commonly use to evaluate this is TE because it gives you a very live view of what's going on. You guys can click on this link and it'll take you to up to date and show you a nice video of what a TE looks like in hypovolemia. We think about it obviously being from hypovolemia, but don't rule out other causes for these patients. I can't stress that enough. Even in young people, you will have demand ischemia that will ultimately lead to an MI. So don't kind of understate the importance of that. Oftentimes, these patients wind up needing blood transfusions as well. Even though they primarily leach out plasma, you will see there's some destruction of red blood cells. So patients going to the operating room to have multiple grafts or multiple procedures done will still have blood loss as well. So have a pretty low threshold to transfuse them. Usually in healthy people, if their hemoglobin gets to like 7 or 8, we're probably going to go ahead and give them blood. And then if their hemoglobin gets down to 10 in the setting of coronary disease, we want to go ahead and transfuse them then. We do use a lot of different agents to prevent or reduce their incidence of blood loss. One of the big ones is like topical thrombin. So we'll put like a thrombin gel or a spray thrombin on these patients so they don't ooze quite as much. Instead of doing long cases, a lot of times we'll take the patient to the operating room multiple times. Those stage procedures work better. They don't have heat loss. They tend to heal better and be under anesthesia for less time. You may also see that we use like subcutaneous vasoconstrictors, so they'll inject epinephrine or phenylephrine underneath the skin, which helps reduce the blood loss. You may see this outside of the burn setting in patients that are having like grafts done. A lot of times they'll infiltrate with like a lidocaine epinephrine mixture for that. There's some recumbent factor 7 being used for burns. One of the problems we ran into with that is it reduces their risk of hemorrhage, but there was a pretty significant risk of thromboembolism. Um, there's only a couple of studies out there that look at TXA in burn patients. And it's kind of a weird setting because, and granted, and like I said from the start, burn patients are increased risk for thromboembolism. But TXA seems to increase that risk as well, which is weird because in all of the other patient populations, it doesn't seem to do that. So just be cautious with that. Now, with that being said, that's intravascular TXA. A lot of times we will use TXA topically in this patient population, as well as potentially by nebulizer. So if you have somebody that's in kind of a shock state, you've given them an appropriate fluid bolus, or you're in the process of giving them an appropriate fluid bolus, you may need to transition to something other than just fluid and colloids. So oftentimes we'll start these patients out on a very low vasopressor infusion. And then as long as we're continuing that volume resuscitation, we may increase the dosage for these folks just to try and compensate without giving them large amounts of fluid. And then, like I said, sometimes we just have to say the fluid isn't working, put them on a vasopressor, and look at CRRT. Tumescent local anesthetic, this is kind of what I was talking about. So for those graft sites, what we'll do is add epinephrine and lidocaine in a liter bag, and they'll infiltrate that area. The nice thing about it is it decreases blood loss. The lidocaine helps out with pain as well. It makes it easier for them to excise granulation tissue, and a result of kind of making it easier to harvest the graft tends to decrease the surgical times. And then they tend to not have all the hematoma and bruising post-op that you would imagine from somebody having part of their skin cut off. So be cautious with patients that are getting tumescent local anesthetics, not only in the burn setting, but also like if you're doing cosmetics in an office or something like that. Um, Kind of there's some variability here, but the 55 milligrams per kilogram is kind of the stated max for these folks. From a mechanical ventilation standpoint, kind of the same goals we always follow. One thing that's a little bit different in burn patients, because they tend to get kind of clots and junk down in their bronchus as well as in their trachea. Sometimes what we will do is add heparin to the albuterol to help break up some of those clots and allow us to suction them free. So what you do is just put 5,000 units of heparin with the albuterol, and then about every 4 hours, give them a neb treatment. And this helps us mobilize those secretions so they're able to get a good pulmonary toilet. And this is just an example of kind of a sloughing injury in the airway. So this is somebody I would think about giving them that heparin and albuterol combination to help get good pulmonary toilet there. If you give heparin alone, it tends to predispose you to bronchospasm. So be very careful with that. That's why we combine the two. And then it gives you a little bit more volume, longer neb, those sorts of things. I talked about this a little bit earlier, but I can't understate this or overstate it enough. Abdominal compartment syndrome is what winds up killing a lot of these folks. We looked at a lot of the data that came out of the Persian Gulf, and what we found was people would survive their burn injuries, but then they would wind up ultimately dying due to the swollen intestines. So not only do you run the risk of an ischemic gut, you also have decreased venous return. You have huge intestines that are pushing up on the lung, so you have ventilation problems. If you have somebody that has to have an abdomen open because of abdominal compartment syndrome in the setting of burns, the mortality is 90%. So not good numbers. So how do we monitor these patients? Well, we should already have a Foley in. So then what we're going to do is just take a look at bladder pressures. Some places measure them every hour, some places every 4 hours. If you have somebody that has intra-abdominal hypertension, a bladder pressure over 12, pay close attention. If you have somebody that gets to be about over 20, start thinking that they've got abdominal compartment syndrome and probably need to go to the operating room for a lab. Post-operative things that we encounter on these folks. If this is somebody that had to be intubated because of airway edema, we're going to keep them intubated. So patients with airway burns, if you have somebody that's really in that acute resuscitation phase and they have a large volume shift that's going on, we probably want to go ahead and keep them intubated because there is, we know we're going to have that pulmonary edema at some point. Patients that are continuing to bleed, patients that are having to go back to the operating room frequently, we may keep them intubated. Now, frequently is kind of a relative term. If this is somebody that's going back 2 or 3 times in a day, yeah, I'm probably going to keep them intubated. Somebody that's going like every other day, maybe not. Other things you have to think about from a surgical standpoint, if this is somebody that has like a critical graft and I need them not to move, I may keep them intubated and sedated to protect that graft. It's also a lot easier to manage pain in patients that are intubated because I don't worry about oversedation or apnea. So that may be an option. Keep in mind, we're going to continue all our other priorities for these folks during this time period. There's not really a great pain scale for patients with burns. So whatever you use the same scale kind of consistently. Your numeric pain scales are fine. Looking at the faces scale is fine. Any of those are options for you. So talking a little bit more about pain for these folks, they're going to be in pain for quite a while. At some point, they kind of get used to the background pain. But what we want to make sure is that in addition to kind of any breakthrough pain, that we're also putting them on something scheduled. Other things that you will see is that we do a lot of stuff to kind of get ahead of their pain. But in getting ahead of it, we also try to give them control over their pain management. So we may put them on a PCA with a basal rate, but we're also going to give them the ability to have demand doses so they can control their pain. Other things that are being used, nitrous oxide in a 50-50 mix gets used. Nerve blocks are a huge one for this patient population. A lot of times we'll put catheters in these patients because this is something that's going to be very painful. And usually that catheter can get them through like the first 5 to 7 days without a problem. Other things that seem kind of straightforward to talk about for pain management, if it hurts, don't touch it. We're real bad about looking at things in the hospital and be like, oh man, that's crazy. Let me poke at it. If you have somebody that's burned, don't touch it. Don't put the blood pressure cuff on it. Don't put the pulse ox on it. Those sorts of things can go quite a ways. And it seems simple, but we do it all the time. Other things to think about, what is this patient going to require as far as like management and strategy? Is this somebody that needs a little bit of extra medication for a dressing change, or do they need like a quick debridement at the bedside? Those patients may not necessarily go to the operating room, but they do need some additional analgesia at that point. Thermoregulations is another big one. So there's a wide variety of treatment options out there. Um, Basic things like put a blanket on your patient. If you're giving them large amounts of fluid, usually we don't think about warming fluid until it's blood. But if I have somebody that's cold and I'm giving them liters upon liters of fluid, warm it up so it's not cold going into them. If this is a patient that's going to be transported, think about the things you can do to keep them warm during that transport. Maybe turn the temperature up in the ambulance, turn up the temperature in the helicopter. There's a lot of kind of warming kits out there. HPMK is Hypothermia Prevention Management Kit, Blizzard. If you were a kid or like you go hunting, there's those little hot hands. There's basically a blanket of hot hands, and you can put that on your patient to keep them warm as well. Those little mylar or solar hats or solar blankets, those work really well too. Anything you can do to kind of trap the warmth with the patient is beneficial for them. Things you'll see with the extremities, a lot of times we put them up on pillows to start off with, because if you don't, the extremities tend to get pretty edematous. So if you can do that, patients do pretty well. Um, you'll see that usually we start off with pillows, and then over time you may see that they're like elevated on like a strap or a sling or something like that. If you're having pretty significant edema, don't move or don't like bypass checking pulses. If you're no longer able to palpate it, you need to move to a Doppler. This can be life-threatening and obviously limb-threatening. If you've got patients that you're losing these pulses, they may need to have an escharotomy done. Same thing, keep an eye on your patient's ventilator if they're mechanically ventilated. If you see that their airway pressures are going up, it could be because they're developing a restrictive insult to their chest. They may need escharotomy for that. So, what is an escharotomy? Escharotomy is basically just cutting through that burn eschar. So it's not exactly the same thing as a fasciotomy. Fasciotomy, you're going down and opening up that muscle fascia. With an escharotomy, you're just cutting through the eschar tissue on the chest. So if you look at this picture on the right, these are kind of the traditional pathways we follow for escharotomies. So basically, for arms and legs, all you're doing is dividing it into an anterior and a posterior surface. For the chest, we almost do like an H pattern, if you will. So you're going to cut down both sides and then free up the chest there. We don't worry quite as much about the abdomen. One thing you'll notice looking at this patient is that these were probably not deep enough. You see how it's still very tense. Um, you probably needed to, or somebody probably needed to cut deeper here to get further down and actually free up that chest. Things to think about as far as like adjuncts to burn resuscitation. Almost all of our patients are under some sort of GI prophylaxis. This is just as important in burn patients. Think about how you're going to secure devices. Like I talked about, a lot of times we see that things get either sewn or stapled in place because tape is not reliable. Urinary output is critical. One of the things that's kind of distracting, just like I was talking about the face being distracting, in male and female patients both, you will see that they tend to have a lot of edema in the perineum. Oftentimes, you don't have to do anything for this other than if that's the burn source. So it may be really impressive, but it probably doesn't require any sort of special treatment, especially if you've already got a catheter in place. Other things to think about, all our trauma patients get tetanus boosters. IV antibiotics are not indicated for burns alone, but you may have an infection that goes along with the burn. So we don't do prophylactic antibiotics in these patients, but they may develop an infection or there may be some sort of coexisting injury. They've got burns, but they've got an open fracture that may require antibiotics. Same thing, we don't do widespread steroids for these folks. It doesn't seem to offer any benefit and does increase their risk of infection. We talked about this a little bit earlier. Most of the dressings done are like topical antibiotics, so like Silvadene and sulfamide. But there are some cool dressings out there. Some of them are like water or saline dressings that keep the surface cool, and they may be traded out every 8 hours or so. You may use like some temporary skin substitutes. One of the most common ones is BioBrain. And it's just like a skin substitute that they can put on there that kind of provides that integrity for the patient. Um, these patients go back to the operating room many, many times. This is the same patient on 5 different OR visits. So, visit one's the initial injury. Then we do skin grafts. You can see after we've kind of debrided everything. Then we go through like in picture D, and you can see as we've started putting grafts on. If you look at kind of that mesh picture in that D lower left corner, that's what it looks like after somebody's had a graft placed. And then this is the patient ultimately coming back many weeks later, looks significantly improved. And there's some references for you. So, what questions do you guys have?